Dr. Sreenivas Kumar, Senior Consultant Cardiologist, Director Cardiology and Clinical Research, Apollo Hospitals, Hyderabad. This video brings to all of you another new important concept in management of heart failure. As we all know, heart failure is a deadly disease and it's more malignant than malignancies. And if you don't take care of these patients, significant number of patients, more than 50% of them would die early. So we all need to give appropriate guideline directed medical therapy to these patients with heart failure. And the beauty of it is if you can give these medicines, 70% of this mortality could be decreased by the treating doctor. Now comes what are the various guideline directed medical therapy which we need to adapt. All of us know that beta blockers, ACE inhibitors or RNA were proven efficacious and we were using. And the stepped care approach which was being followed of gradually giving one drug and building up the dose of the drug till the patient tolerates and then getting on to other drug. In this process, we were losing a lot of important time and some of the patients were dying in this therapy building duration. So the latest concept what is proposed in the recent guidelines and EDP pathway is we need to give the 4 drugs which are 4 pillars of heart failure therapy in 4 weeks. I request all the doctors to take the serious note of this. 4 in 4 is a new concept in congestive heart failure therapy. Number 1 is the first step we give beta blockers and along with it you need to start SGLT2 inhibitors and that is recommendation wise it has come because probably the data of SGLT2 inhibitors, EMPA and DAPA has come up so hugely that these patients significantly benefit with this molecule. That's how they have come up in the ladder in the management of heart failure. So along with beta blockers, you straight away start this empagliflozin molecule for the sake of benefiting this decreasing heart failure mortality. Then you add up and go on to ACE inhibitors or RNA, and then the third would be mineralocorticoid receptor antagonist addition. If you can give all these patients all the important drugs, then you can decrease mortality by 3/4. I would like to stress upon empagliflozin, the molecule of today's discussion is basically because all of us, all the cardiologists I mean, need to become comfortable with the usage of this molecule. It is no more anti-diabetic drug. Actually, it is become more of a heart failure drug than the diabetic medication. And the recent guidelines and even DCGA approved this even in non-diabetic heart failure. We knew before that in diabetic heart failure, it significantly decreased mortality. And then even in non-diabetic heart failure, the decreased hospitalizations and mortality were noted significantly with the usage of this molecule. Another interesting aspect which is not there even with ACE and RNA is that worsening of kidney function or the progressive decline of renal function is actually prevented much better, though there is not direct comparison, but the usage of this molecule prevents worsening of kidney function little more better than ACE inhibitors and RNA. So I wish all of us become more wiser and use this important molecule in the patients of heart failure. So start with beta blockers and SGLT2 inhibitors, add up ACE or RNA and then mineralocorticoid receptor blockers. Thank you Lupin and for bringing this important molecule in a less costly way to our country. I wish all the doctors use this molecule and help the patients of heart failure survive better. Thank you.